Hi, guys, and welcome to another episode of Dr. Suresh Reacts. In today's episode, we are looking at this video here today by Dr. Ken Berry, of course, fairly renowned, esteemed YouTuber in the health space, keto carnivore space. Real heart attack causes revealed and what you can do 2024. This was posted a couple of months ago, and one of my silver member subscribers asked me to have a look at this, so that's what we are doing today. Now, in this video, I agree with a lot of what Dr. Ken Berry is saying, but I will provide some additional commentary and some additional thoughts. Like always, most of what he says is correct, but there are a few points that I do think just need some clarification. So let's get on with the video.
Hello, my friends. Dr. Ken Berry here, family physician with over 22 years of clinical experience. Today in this video, I'm going to tell you exactly what you need to know to reduce your risk of having a heart attack, definitely, but also most likely a stroke as well.
He doesn't actually tell you that at all, but let's let him continue.
So we hear so much conflicting information on social media. If you read magazines, if you still watch TV, I mean, who still watches TV? But you get all these conflicting messages.
I do occasionally, very occasionally.
And when you go see your doctor, invariably, all they want to talk about with regards to reducing your risk of having a heart attack is your LDL cholesterol, or maybe your ApoB, or maybe your total cholesterol if your doctor's 10 years behind on the reading.
Yeah, I mean, look, that's probably true. Most doctors will focus on LDL cholesterol and total cholesterol. But there's a lot more, of course, to it than Dr. Ken Berry goes into today. So we'll give him the benefit of the doubt so far.
I wanted to show you a graph. Now, this is shown in a British Medical Journal Open Heart back from 2021, written by Professor Noakes. And it's
Professor Tim Noakes, who many who follow me watch these videos will probably know who Professor Tim Noakes is. Famously advocate for low carb from South Africa, of course, was criticized, penalized, punished, went after by sugar companies, pharmaceutical companies, etc., for trying to promote low carb diets. Of course, actually, I believe used to be in the health space as far as promoting carbohydrates and sugary foods and so on. So yeah, interesting turn of events there. He's talking about this because he's trying to give some credence to the graph that he's going to present here, saying it's in a British peer-reviewed journal, which it is important, of course. Open Heart is a prestigious journal. Let's let him carry on.
Got a graph in it that just makes this so crystal clear.
For some people, I'll explain.
And so plain that anybody, regardless of their IQ or education level, can understand this. So,
at a very superficial level, yes. But there's more to the story, as always.
I'm going to put this graph up on the screen, and I'm going to walk you through what you see in this. So here's the chart. Now, this gives you the hazard ratios for development of coronary heart disease.
For women. Not for anybody else. For women. This is the Women's Health Study. And this is specifically postmenopausal women in the Women's Health Study. So this is not for men. This is not for children. This is not for, elderly people specifically. This is for women, postmenopausal women specifically. So whilst this is predominantly accurate, we have to just bear that in mind. This is not for every single person that this graph represents. It is for women. Dr. Ken Berry should be making this very clear. Yes, I am pedantic, but I think pedantry is important. This is not just semantics. These are important points. And this is something that I have criticized many people doing, not being specific with the wording that they are using. It gives people the wrong idea. And whilst it may be predominantly accurate, and it is, this is specifically for women. And I think we should be specific in the message that we are giving people.
So a hazard ratio means how likely is this to cause what we're talking about? How big of a risk is this? So you can use the different lengths of the bars on this bar graph, and it will tell you this is the most important thing. This is the next important thing. So if you look at the top part of this, the red bars, the biggest thing that's going to give you the biggest risk is type 2 diabetes.
Correct. And that is true across pretty much all populations. Whilst I'm saying this is for women specifically, because this is from the Women's Health Study, postmenopausal women, this will apply to pretty much everybody. So I will give him leeway here. Look, it's YouTube. There's a certain amount of creative license you have to afford people to get views and clicks and so on. And it's not clickbait, but he could have been more specific. Type 2 diabetes is in a long way, the biggest risk factor for heart disease, and by extension, most likely stroke and other vascular disorders, as what's going on here is likely what's going on in the brain, in the neck, in the kidneys, pretty much everywhere else. But again, let's be specific with these things.
And also, you can include in this uncontrolled type 1 diabetes, but the vast majority.
Look, yes, you probably could. But uncontrolled type 1 diabetes, I guess it depends on what level of uncontrolled you're talking about. Completely uncontrolled, I mean, you're basically dead. So you're not going to feature in a study. Also, type 1 diabetes, as far as I understand, was not featured in the Women's Health Study. Hardly any, if at all. I struggled to find the actual data. I have tried to go through the Women's Health Study. It is very difficult to often find the original data. Things like Framingham Heart Study is a good another example. It's a very long follow-up. This is basically similar to Framingham over 20 odd years. It's very difficult to actually find the raw data to actually go through. Type 1 diabetes, I don't think, though, is featured in the Women's Health Study, given that this is postmenopausal women, so 50 plus, pretty much by definition. You're very unlikely to have people with uncontrolled type 1 diabetes in that age group. But yes, uncontrolled type 1 diabetes is going to be a big risk factor for coronary artery disease. There is no doubt. But you're likely to die of other problems before a heart attack, I think.
Majority of people with diabetes have type 2 diabetes. It has a hazard ratio of 10.71. That's huge. This is almost as big as the hazard ratios from the smoking will cause you lung cancer research studies from a decade or two ago.
Yeah, I think on average, on memory, that was about maybe 12 to 15. I can't remember exactly. But yeah, it's getting up there. So this is the relative risk ratio. This is the hazard ratio, saying if you have type 2 diabetes, you're about 10.7 times as likely to suffer coronary heart disease. But is that a heart attack? No, not necessarily. Again, you'd have to really go into the data to accurately determine. But this is coronary artery disease, not heart attacks. Those things are separate. Whilst one will lead to the other, coronary artery disease will inevitably lead to heart attacks if left unchecked. Again, the specifics here, to be pedantic, this is coronary heart disease, not heart attacks.
A hazard ratio of 10.7 is huge, okay? So if you currently have type 2 diabetes, that is far and away your biggest risk factor for having a heart attack, regardless of the fact that all your doctor wants to talk about is your LDL cholesterol and wants to get you on a statin.
And there we come to it. I knew we were going to be coming to statins. Doctors, influencers on YouTube, it's an easy way to get clicks. It's an easy way to get likes if you just are anti-statin. And look, I've got videos on statins coming out soon. I've done videos on my main channel at The Meat Medic. I don't like statins. I think they are vastly over-prescribed to people. Do not get me wrong. I am not pro-statin on the whole, but for the right patient, for the right problem, yes, they can be useful. I told a patient today who's fairly recently had a heart attack, they probably should stay on the statin, but we've compromised and we've reduced their dose down because the most benefit comes from actually a low dose, not necessarily a higher dose, but more symptoms come from the higher doses. So actually, all he probably needs is just to be on a very low dose of that statin. But this is where we come to it. Whilst type 2 diabetes is the biggest risk factor and statins won't do anything for type 2 diabetes, in fact, they may actually slightly worsen it, that's not the same as saying that statins won't do anything if you have coronary artery disease and you have type 2 diabetes. Statins have this protective role. when it comes to coronary artery disease. If we're being honest, if we're being truthful, and this is really what this series, these episodes are about, it's not about getting likes and clicks and views and so on. It's about being truthful and presenting my honest opinion as a doctor, as a specialist GP, as a board certified lifestyle physician who does this work day in, day out with patients. And I am the one that is seeing the patients. And my understanding is that Dr. Ken Berry no longer sees patients face to face. So you can say what you like on YouTube and it doesn't really matter because you're not the one that's actually dealing with the patients. You're not the one that they're going to get complaints about when they have a heart attack, a subsequent heart attack. You're not the one that's going to get sued because you told them that statins are not good for them, because you're just giving general advice. I'm the one of the doctors who is actually at the coalface, seeing people and helping them to make these decisions. Statins have this protective anti-thrombotic, anti-clotting, basically anti-heart attack protection. They give this kind of, I suppose, mesh lining, if you can call it that. They help to calcify soft, unstable plaque into hard, stable plaque. Now, that benefit isn't necessarily dose dependent. So you don't necessarily need a big dose of statins to get that benefit, but a small dose of statin might give you that benefit. So actually, this is why it's in the guidelines for here in Australia, I'm sure probably in America, the UK, all over the world, most likely, for treating type 2 diabetes with, giving them a statin is because it can give them a cardioprotective effect. So, Berry, you are slightly wrong or perhaps misguided or just giving slightly misinformation on this point.
We'll get to that in a minute. Your biggest risk is having type 2 diabetes. The second biggest risk, also a very big risk, is having metabolic syndrome,
which is basically pre-diabetes. So yeah, insulin resistance, metabolic syndrome. If you've got a waist circumference above 100 centimeters as a Caucasian male, as a Southeast Asian male, if it's above 90 centimeters, as a female Caucasian, 80 centimeters, Southeast Asian female, 70 centimeters. If your waist circumference around your belly button, not around your hips, and not lower down underneath your gut and all the rest of it. So let your gut just hang there, measure around your belly button properly, don't cheat. If it's above 100 centimeters as a Caucasian male, like Dr. Berry, I put myself in that category as well, though technically I'm mixed race, but that's not really a subject for this YouTube video. I have Southeast Asian descent, Indian descent, but I don't really quite fit into that category either. As far as the metabolic syndrome, and you have high blood pressure, you almost certainly have metabolic syndrome. If you just have a raised waist circumference, you probably have metabolic syndrome anyway, which is a huge risk factor for everything, not just heart disease in this case. But metabolic syndrome and hypertension, obesity, they're basically all pretty much one in the same.
So this is a syndrome of having high triglycerides, high blood pressure, a large waist circumference.
Technically, it's dyslipidemia, not just high triglycerides, but internationally, there isn't really a consensus on exactly what qualifies you for having metabolic syndrome. The Europeans, the British, and the Americans have all slightly different criteria that they like to apply for. Even then, it's not necessarily agreed within those countries. So it's a bit of a judgment call sometimes.
And a couple of other things. Metabolic syndrome, number 2 biggest risk factor of all.
I mean, just go back a little bit there. It's not really a couple of other things. It's basically dyslipidemia, high waist circumference, and high blood pressure. Those are pretty much the 3 things. There's nothing else really as far as metabolic syndrome is concerned. Though you do see things like low testosterone, high insulin, all that kind of stuff, which isn't really part of any international criteria.
Now, the further down at the bottom of this chart, the blue bars are biochemical markers. These are lab results that we can say, yes, that has a hazard ratio that we can calculate. So number 1, type 2 diabetes. If you've got that, that's where you need to focus all of your effort, all of your money, all of your willpower. You need to do whatever reverses your type 2 diabetes back to normal. Now,
which will also treat the metabolic syndrome, the high blood pressure, the obesity, and not the smoking inherently. But yes, if you can stop smoking as well, that is very, very good. But that's not the same as saying that you don't benefit from a statin, which is the implication here that he's trying to suggest that people don't need a statin if they just fix their type 2 diabetes. Statins can help people who have already existing terrible plaque burden. Fixing your type 2 diabetes may not, fix the plaque burden. Just remember that.
Now, I've got hundreds of videos on my YouTube channel. You can watch my keto videos or my carnivore videos. Both of them are going to reverse your type 2 diabetes back to normal.
Will they though? Keto? Yes, definitely. But why do people get a raised blood sugar on the carnivore diet? Is that curing type 2 diabetes? Well, they probably don't have diabetes anymore, but they can almost get into the pre-diabetic range, which is a big risk factor. And they're basically falling in this kind of lipoprotein insulin resistance kind of area, which, yeah, might actually be an issue.
And erase the biggest.
I'm talking about a strict carnivore diet, not just a carnivore adjacent diet, which is basically keto or ketovore. That's what I currently do. I think that works really, really well. But a strict carnivore diet has some issues.
Risk factor for coronary heart disease, which is what leads to ultimately having an acute myocardial infarction, aka a heart attack.
No, it doesn't. It can certainly increase the risk. It doesn't inevitably lead to having a heart attack. A lot of people have quite advanced coronary artery disease and never have a heart attack. It's not great. Don't get me wrong. I'm not advocating for having coronary heart disease. No, God, no. But that's not the same as saying it's inevitably going to give a heart attack.
Also, keto and carnivore reverse metabolic syndrome back to normal.
Keto, yes, definitely. Carnivore adjacent, yes, definitely. Strict carnivore, initially, yes. Long term, I've seen markers of metabolic syndrome, the dyslipidemia, maybe not the waist circumference, but the high blood pressure creeping back in after a while on strict carnivore diets. Believe it or not, I have seen this.
So,
exactly why, I honestly can't tell you, but I've seen it.
Literally, by changing your diet and eating what I call a proper human diet,
which is not really keto or carnivore, just saying,
you're going to erase the two biggest risk factors for having a heart attack.
If you're a postmenopausal woman.
Now, number 3 on risk factors is hypertension. That's high blood pressure. Guess what is going to lower your blood pressure back either to normal or to near normal? A ketogenic diet or a carnivore diet.
Yeah, likely would happen. Would help, sorry. Carnivore against strict carnivore, yes, initially, definitely, 100%. I've seen it dramatically lower blood pressure, dramatically. Longer term, I've seen blood pressure start to creep back up, though. Keto, definitely. Proper human diet from Ken Berry, I'm sure, would also do the same thing, though it's not strictly keto or carnivore anyway. Carnivore adjacent, like I do, my Primal Fusion diet, which you guys can check out at primalfusiondiet.com or links at themeatmedic.com. Also is basically pretty similar to the proper human diet, though with some slight tweaks in there. Yes, it's very likely to help treat type 2 diabetes, metabolic syndrome, and high blood pressure, though these are not guaranteed.
We have seen this in hundreds of thousands of people
who actually commit to making the changes. Yes. You can't just kind of do like a bit of keto, doesn't work. And keto carnivore doesn't just magically reverse, coronary artery disease. And this is the issue I have with some videos like this, is people like Ken Berry basically telling people you can cure heart disease, you can get rid of your heart disease if you just go keto or carnivore. Now, he's not saying that specifically, but that's the intimation, that's the kind of implication that he's making here. Yet it doesn't happen like that. I mean, I had a patient about 18 months ago now who came to see me who had type 2 diabetes, terrible type 2 diabetes for a long time, about 20, 30 years, and was diagnosed really late, having all these issues. And he found carnivore, whatever, went on the carnivore diet, came to see me, was doing really well. His lipids came right down, triglycerides came right down, his blood pressure came right down. He felt great, losing loads of weight, yada, 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 all absolutely amazing. And then 2 months later, he had a heart attack. Was that carnivore that caused the heart attack? No, it was not. It was clearly the 30 odd years of terrible, terrible diabetes control. But that's my point. Keto and carnivore can't just magically cure heart disease. It doesn't magically stop you from having a heart attack. And this is the concern that I have with people like Ken Berry. I'm not specifically singling him out, just the carnivore keto influencers, basically telling people you don't need statins, you don't need to do anything. All you need to do is go keto or carnivore and you're going to be magically fixed. Life doesn't happen like that.
People come to either keto, carnivore on 1, 2, or even 3 blood pressure medications and their blood pressure is still high. That's hypertension. That is increasing their risk of having a heart attack. It has a known hazard ratio.
Yeah, big risk. And keto carnivore can definitely help with that for sure. But you still may need some tablets, maybe.
If you'd like to know how an affiliate marketer in Australia can go from small, irregular income
Bloody
like
ads.
this to reliable paid.
When you adopt a real whole food ketogenic diet, not full of keto treats and cookies and cakes and pies, but
Which are all bullshit garbage. Yep.
real whole food keto, or a carnivore diet, you're going to lower your blood pressure. And the more you lower it back towards normal, the lower this hazard ratio is going to be.
You may lower it. This is, again, the issue I have with people like this. Being pedantic. People get the wrong idea, though. And I see this all the time. I see patients who have basically been promised the world through keto carnivore, and it's just not manifesting. The problem is they think it's going to. And they listen to people like Berry, like Chafee, like Baker, etc., who are kind of almost really espousing this anti-doctor message and saying that you don't need medications, you don't need to go and see your doctor, you don't need to do blood tests. All you need to do is do keto carnivore and you're going to be great. Everything's going to be hunky-dory. It just doesn't work like that. But people are getting that idea. And so they're being very resistant to getting these things under control. They want to do the diet and everything changes, which is fantastic. And look, that is what I like to do. I'm a board certified lifestyle physician. I want to deprescribe. I want to get my patients off medications, but I ultimately want to help them to treat their illnesses in the best way possible. And that might mean, at least short term, some medications. Problem is, people hear messages like this and then they just think, I don't need to do anything other than go keto carnivore. They don't go and see their doctor. They don't get the checks. They don't get the health checks done. They don't get the blood test. They don't get the blood pressure checked. They don't do the CT calcium scores and all these other things. And then bam, they have a heart attack because they never saw anybody and they never actually took it seriously. They never got any checks because the messaging they're given is just go keto carnivore and everything will be fantastic. It's just not the case.
Number 4 on the list in the red bars is obesity. Now, I think everybody on planet Earth now knows that both a ketogenic way of eating and a carnivore way of eating is going to help you lose fat.
But it's not guaranteed. A lot of people don't. I mean, I saw 3 people today on the carnivore diet that are struggling on the carnivore diet, not losing weight, not feeling good, not having the amazing benefits that everybody has been promising them. 3 new patients today out of like 20 patients that I saw today struggling on the carnivore diet, not seeing these amazing health benefits that everyone's promising them. It's not a magic pill.
Weight. It's going to help you reverse your obesity. Definitely help you reverse severe obesity. And
yeah, severe obesity, probably, yes.
In many cases, reverse your overweight back to normal. You're going to
yeah, if you do it right,
move back towards the normal body weight and body fat percentage. So 1, 2, 3, 4, the top 4 risk factors for having a heart attack, a ketogenic diet, or a carnivore diet completely reverse those risks back to normal and erase these hazard ratios.
It might do. It might do. It probably will. It probably will. But the caveat there is it's not guaranteed. You've got to work at it. And it's a long time thing. You've got to go and see doctors who are versed in keto and carnivore, like myself. And if Australian patients, you guys can consult with me. Details at themeatmedic.com, international pages. Patients, I can do coaching. I just can't do blood tests and drugs prescribing and all the other things there as well. My insurance doesn't cover that. But yes, look, you can do this, but you've got to see a keto carnivore friendly doctor who's actually going to do these tests for you, who's actually going to be monitoring these things for you. You can't just go keto carnivore and say, great, I'm not going to have a heart attack anymore. It doesn't work like that. I wish it did. I wish I could be out of a job. I wish I could stay at home and just do nothing. but I can't. There's always going to be people that struggle on these things because it's not a magic pill.
Now, look what's number 5, smoking. Now, we all know how bad smoking is. Smoking is very bad for you. If you smoke, please stop smoking. But when you compare smoking to type 2 diabetes, type 2 diabetes is orders of magnitude, or at least orders of multiplication, more dangerous than smoking for your risk of having a heart attack.
But you should still quit smoking. I think more emphasis could be made on this point that, it's a 4 times risk factor virtually. If you're smoking, you need to stop smoking. Smoking is very, very bad for your health. It cannot be overstated how bad it is for your health. And vaping is most likely not much better.
Metabolic syndrome is more dangerous than smoking. Hypertension more dangerous than smoking. Obesity more dangerous than smoking. And then finally,
okay, but we should still quit smoking.
We're all told that everything's genetics, right? Your family history of premature coronary heart disease, that's genetics. Look at that. It's a hazard ratio of 1.5. When you compare that to the type 2 diabetes hazard ratio of 10.71, your family history suddenly becomes much less important because you can't do anything about your family history.
Yes, you can't. He's absolutely right. But that doesn't mean you should ignore it. And that doesn't mean you should just go, well, I just don't care because I can't do anything about it. No, it's still increasing your risk by 1.5 times. It's still important. And as far as genetics, look, I call genetics one of the 3 universal scapegoats that doctors give. So, and it's changed over time. It used to be just you're fat. That was the universal scapegoat number 1. So any problem that you went to see your doctor with, you'd basically just get told, oh, it's because you're fat. It's because you're overweight. It's because you're obese. But that became less politically correct. It became more sensitive, and then fat shaming, all the rest of it. People have issues with that now, of course, telling people that they're overweight. Nobody wants to tell patients they're overweight. Patients don't want to hear that they're overweight. So that universal scapegoat kind of disappeared. The next universal scapegoat, number 2, was autoimmune, quote unquote. So any problem that you had was then autoimmune. And then it was genetics. And basically, I call them these universal scapegoats because they're kind of things that you can't really do anything about. And so where doctors can't help you when they're struggling to find the information to help you, they basically just tell you, oh, it's genetic because, then they're kind of absolved. They don't have to do anything because, well, you can't do anything about genetics. But here's illustrating here that genetics actually don't make necessarily a huge difference, but you should still pay attention to it.
Your genes, you can't really affect them, but you can reverse your type 2 diabetes and your metabolic syndrome and your hypertension and your obesity. And if you're smoking, you're going to stop smoking because that's dumb. Now let's look down at the blue bars, the biochemical markers. These are lab tests that you would get ordered. The most dangerous is lipoprotein insulin resistance. This is another way of talking about hyperinsulinemia. I've got multiple videos on my YouTube channel about what can you do about hyperinsulinemia.
It's more than hyperinsulinemia, though. Insulin resistance is 2 sides of one coin. So it's high insulin, which is hyperinsulinemia, and insulin resistance. So resistance to that insulin. Having a high insulin level in and of itself isn't necessarily harmful. It's the resistance that's also a problem. Now, they go hand in hand, of course. Don't get me wrong. I'm not arguing for having a high insulin level. It's generally very bad. But a fasting insulin, which a lot of keto carnivore influencers, people like Dr. Ken Berry, people like Chafee, people like Baker, Judy Cho from Nutrition with Judy, all these carnivore influencers and so on talk about fasting insulin. But what they're missing is there's more to the picture than just a fasting insulin. The insulin resistance is your whole kind of metabolic panel. It's this, I suppose, complex, if you will, this syndrome. It's not just a single test. And it's even just a made up term, this insulin resistance. It's just a thing that people have coined. There isn't a one single test for insulin resistance. I'd love to actually dive into the Women's Health Study and find out how they measured this, how they determined this, but I couldn't find, unfortunately, that information. But my point here is keto, great. Strict carnivore, I've seen signs of worsening insulin resistance over time. It's very much this kind of U-shaped curve. So it starts really high with people, drops right down when they go on carnivore, almost to 0. and then very slowly starts to just creep back up a little bit over time. The other markers of insulin resistance, not fasting insulin, that typically stays low, but other markers of insulin resistance, other signs like fasting glucose going up, HbA1c going up, triglycerides going up, HDL going down, LDL going up, total cholesterol going up, waist circumference becoming static or even going up, weight not shifting going down, blood pressure starting to go up, hormones going down, etc. That whole metabolic syndrome picture starting to creep back in on a strict carnivore diet long term, a very strict carnivore diet.
You can eat a very, very low carbohydrate diet, aka a ketogenic diet or a carnivore diet.
Carnivore is zero carb, not low carb, not very low carb, not ultra low carb. It's zero carb. There's a difference.
Next on the list, with a hazard ratio of 2.14, high triglycerides. Guess what? Completely returns your triglyceride marker to normal. A ketogenic diet or a carnivore diet.
Short term, yes. Long term, I've seen issues on strict carnivore, not on keto. Also, if you have familial hypertriglyceridemia, if you have familial hypertriglyceridemia, this probably will not work. You probably do just need medications for that one. It is a big risk factor.
So the top two, you can completely get them back to normal by eating what I call a proper human diet. Number 3.
I'd love to see if there's any studies on that. No, there isn't. I don't think Ken Berry's done any studies on his proper human diet at all. To be fair, I haven't done any studies on my Primal Fusion diet either. So, but to make claims that this will do that might be a stretch when it's not proven.
Apolipoprotein. Now, we touched on that earlier. I have more videos to come on my channel as we go. But look at apolipoprotein with a hazard ratio of 1.89. It has a known hazard ratio, but compare that to the hazard ratio in the red bars of type 2 diabetes or metabolic syndrome or hypertension or obesity or smoking. It's a very small hazard ratio. What about non-HDL cholesterol, 1.67? Let's compare that to type 2 diabetes. Should your doctor even, and then finally, we make it all the way down to elevated LDL cholesterol with a hazard ratio of 1.38, which is approaching background noise. Compare high LDL's hazard ratio of 1.38 to type 2 diabetes hazard ratio of 10.71. Type 2 diabetes is 10 times more dangerous than having high LDL cholesterol.
No, it's not quite. It's about 8 times actually, if you do the maths. But they're different things. They're not the same thing. They're not opposite. So why is he going on about type 2 diabetes is the biggest risk factor? It is. But the implication there is, who cares about your cholesterol because it's a smaller risk factor? That's just a stupid argument, and it's a stupid way of thinking about things. It's totally illogical. If you've got coronary artery disease or you're at risk of coronary artery disease, you need to be addressing all of those risk factors. Now, this, of course, has the caveat that LDL cholesterol, this is going to be in a standard population eating predominantly a standard diet. I don't think these people were doing ketogenic or low-carb carnivore diets. So standard diet, LDL cholesterol is more likely to be damaged, more likely to have small, dense LDL. And that's really where the risk factor comes in. If you looked at small, dense LDL specifically, it would likely be a much higher risk factor than the total LDL or the LDL, non-HDL or total LDL cholesterol. But we're not talking about that here because we don't have the information. Interestingly, again, keto, I've seen LDL, small dense LDL go down. Strict carnivore, repeatedly, I have seen small dense LDL going up on a strict carnivore diet. This is a concern that I have on a strict carnivore diet, zero carb diet, never having any vegetables, never having any fruit, never having any dairy, zero carb intake, just muscle meat, maybe eggs. This is a concern that I have, this small dense LDL actually going up. And I have seen this now in dozens of patients. This is not a one-off. This is 100% of my strict carnivore patients, I've seen small dense LDL going up. I have not seen it, I think, on a single, maybe one, possibly, keto or low carb patient. Ketovore, don't see it. Carnivore adjacent, don't see it. It's the strict carnivore, as taught by people like Dr. Anthony Chaffee, that's causing problems for people with small dense LDL, which is a huge risk factor for cardiovascular disease, much bigger than total cholesterol or LDL specifically. Still not as high as type 2 diabetes, but still it's very, very high.
Now you understand why I get so furious when that's all doctors want to talk about is, oh, your LDL's high, we've got to get you on this medication, and completely ignore your high blood sugar, your high insulin levels, your moderately high blood pressure. They ignore all that. All they care about is getting you on that statin.
Yeah, look, that's going to get clicked on YouTube, but is that true? Probably not. Look, most doctors overprescribe statins. Absolutely. Do most doctors care too much about cholesterol? Yes, absolutely. But this is what the guidelines are suggesting. As I said, it's very easy to sit there on YouTube and criticize people when you're not the one seeing patients. You're not the one that's having to make these decisions to help guide patients. You're not the one that's going to get sued when it goes tits up and you have problems and your patients have problems. It's all well and good just cursing other doctors on YouTube. It gets you followers, but it's not accurate. It's not true. As I said earlier, statins do more than just lower cholesterol. And Dr. Berry knows full well what statins do. He knows that statins are going to reduce your risk of cardiovascular disease if you have type 2 diabetes, metabolic syndrome, and high blood pressure and obesity. They are very likely to help you in that scenario. What would be better would be to fix those problems. But that's not the same as saying that statins are not good for you. But that's the implication that he's clearly making here.
Or on Repatha or Praluent,
which are PCSK9 inhibitors, which are garbage. Nobody should ever be on those. The Fourier trial clearly demonstrated that whilst cholesterol went down, cardiovascular disease and deaths went up. So definitely PCSK9 inhibitors, I would never take them. Let's put it that way.
It's inappropriate. It's bad medical practice.
No, it's not. It's actually good medical practice. It's just maybe slightly misguided. But it's good medical practice in the sense that statins can help these patients because they have an extremely high risk of cardiovascular disease. This is independent of the LDL cholesterol. A small dose of statin is likely to be beneficial. So it's not even really misguided. It's not bad clinical practice.
And it's not truly protecting you from having a heart attack.
No, nothing is going to truly protect you from having a heart attack. Nothing is guaranteed. But for very high-risk individuals, people with terrible type 2 diabetes, metabolic syndrome, high blood pressure, obesity, that smoke, all of these things, yes, a statin is going to actually reduce their risk. That is the truth of the matter.
If you're currently, if you're a type 2 diabetic and your doctor's got you on 2 or 3 different medicines, but your hemoglobin A1C is still 6.5, 6.7, 7.0, and your doctor says, well, that's pretty good, they're ignoring a hazard ratio of 10.71.
No, they're not. We don't actually know from the Women's Health Study, because I couldn't drill down into the data, where this ratio actually comes from, what the measurements actually were. I'd love to know, and I tried to find this information. It could be type 2 diabetes is just 6.5% plus. That might be how they categorized it. That is technically the cutoff in most parts of the world for an HbA1c of 6.5 is cut off for type 2 diabetes. It could have been 7% plus. It could have been 8%, 9%, 10%. I don't actually know. Most likely it was 7%. That's typically what they tend to use for these things. But the other thing is, again, when you're sitting in an ivory tower, you're not seeing patients, you're not the one that's actually doing this work for people, it's very easy to criticize everybody else. People there, GPs, doctors, cardiologists, diabetologists, endocrinologists, they have 10, maybe 20 minutes at most with the patients with a multitude of health problems. Most of these people cannot possibly even remotely contemplate thinking about curing their type 2 diabetes because they just, for various reasons, just don't have it in them. Yes, it would be ultimately much better if they could do that. But otherwise, being on that statin is the lesser of two evils, because otherwise they just go on nothing and they have no protection at all. As I always say to my patients, you can either be healthy or you can be on the statin. The problem is the vast majority of people are actually really unhealthy. And so they do actually benefit from that statin. And unfortunately, as much as I would like them to change, often they just won't, they can't, they don't.
And then they're got to get you on the Crestor. They're focusing on a hazard ratio of 1.38.
No, they're not. Because again, that's cholesterol, not statins. There's a difference. And Dr. Ken Berry knows this full well, but he's just amping it up for YouTube.
Does that make any sense to you? And then,
yes, it does, as I've explained numerous times.
Finally, the lowest hazard ratio on this list is inflammatory biomarkers like HSCRP. Many doctors and health influencers out on the internet want to talk about your levels of inflammation, and it does matter. But let's put it in context. You've got a high HSCRP, okay. How does that compare to having type 2 diabetes or metabolic syndrome or hypertension or obesity? It's a tiny risk factor compared to those risk factors. So what I recommend you do is focus on the biggest bars on this graph. If you've got type 2 diabetes, you don't need to be thinking about anything else in the world with regards to improving your health than doing whatever it takes to reverse the type 2 diabetes so that you go back to having a normal hemoglobin A1C.
Yeah, I mean, he's right and he's wrong. There's more to think about, as I've mentioned numerous times, statins, because that's what he's focusing on here. Anti-statin, basically, medication, anti-statin rhetoric. Medications like statins can be useful. Medications like high blood pressure can be useful. Medications to lower type 2 diabetes, HbA1c can be very useful. No, they're not going to cure it, but they can significantly improve it, which is going to lower your risk of cardiovascular disease. Yes, he's absolutely right that we should do everything you possibly can to lower your type 2 diabetes, get rid of it, cure it completely, get rid of metabolic syndrome, hypertension and obesity and smoking. 100%. Absolutely no question about that. But that doesn't say, it's not to say that you shouldn't just do everything that you possibly can, which might also include medications at this point. And just an interesting note about HbA1c. Why is it on strict carnivore diets, HbA1c goes up? And yet he's saying do everything you possibly can to get rid of HbA1c, get it down as low as you can. Yet on strict carnivore, it goes up. Is that a good thing then, or is that a bad thing? I know what I think.
Once you've fixed your type 2 diabetes, then you'll pick the next biggest bar, which is insulin resistance, hyperinsulinemia, if you look at the blue bars, or metabolic syndrome, if you're looking at the red bars.
Which are basically one and the same, as well as hypertension and obesity. They're all basically the same thing. He does a lot of funny faces in this video. I think he's just trying to dramatic effect here.
The same thing is going to fix both, which is a very, very low carbohydrate diet.
Yeah.
You're going to remove these as risk factors in your personal equation when you reverse these numbers back to normal.
Not technically true. You won't reverse them. You won't remove them completely. They're still going to be there, as they often say. This is one of the, again, criticisms I have with some of these keto carnivore influencers. They obfuscate and they kind of, how to say it, they misinform people a little bit, intentionally or not, I don't know. And, they say on one hand things like, well, don't worry about going carnivore. If you have a heart attack on carnivore, it's because it takes 40 years for heart disease to develop. And then they say, well, go carnivore because it's just going to fix heart disease. It doesn't take 40 years. It takes 40 years to develop. It doesn't just magically cure heart disease. And then when someone has a heart attack on carnivore, they say, oh yeah, but that's because carnivore can't fix heart disease. It doesn't just cure 40 years of heart disease overnight. But then they tell people go on carnivore and it will cure your heart disease. Which is it? It can't be both simultaneously, Schrodinger's diet. It can't be both simultaneously in and outside the box at the same time. It's got to be one or the other. Either it does cure heart disease or it doesn't cure heart disease. It can't do both at the same time.
So stop worrying about your LDL cholesterol if you've got metabolic syndrome or type 2 diabetes or hypertension or obesity or you smoke.
No. Totally false, totally incorrect, totally bad information. No, Dr. Ken Berry should know better than this. This is disastrous health advice. Your LDL cholesterol matters. If you have smoking, obesity, type 2 diabetes, metabolic syndrome, and hyperinsulinemia, it matters a great deal. Why? Because it's going to increase your small, dense LDL. You want those large, big, buoyant, fluffy LDL particles that have no association with cardiovascular disease. You don't want the small, dense LDL particles which have a big association with cardiovascular disease. Those are going to increase your risk of your LDLs becoming those small, dense LDL. So if you have those problems, you absolutely need to worry about your LDL. Ideally, the best solution is to get rid of those problems, and then likely your LDL is going to improve. But that's not the same as saying don't care about your LDL. That is bad, dangerous advice.
It's a minor risk factor.
No, it's not, as I've said repeatedly.
Okay, I hope this chart really helps you understand. You only have so much time and motivation and money and willpower and stamina and self-control. Focus all that you've got on reversing the biggest hazard ratios on this chart. And you're going to do that by adopting a proper human diet, a diet that's very low in carbohydrates, whether that's a ketogenic diet, a ketovore diet, or a carnivore diet. Now,
ketovore would be my recommendation, not strict carnivore, but I've already said that numerous times.
I hope this video helps, and as always, you're welcome to leave your stories in the comments. If you've already reversed type 2 diabetes by eating a proper human diet, tell me your story in the comments. People love to read those because that's the real life experience of a real human who's just like them. And also,
and then we go on to the cell about trying to join his community, so I'll leave it there. Yeah, look, I mean, I think I'll leave the chart up here with the graph and so on the page. What Dr. Berry is saying here predominantly is correct. That type 2 diabetes is a massive risk factor. Metabolic syndrome, hypertension, obesity, smoking, hyperinsulinemia, and insulin resistance. These are massive risk factors for heart disease and subsequent heart attacks. But he's wrong on a number of points. Number one, if you have those problems, you absolutely should be thinking and worried about your LDL, specifically the small, dense LDL. All my patients, I usually tell them to get this test done. For those I'm doing metabolic work with, my routine patients I do, but they generally don't bother getting it done because cost is an issue. And it's right, if people have only got so much capacity, financial, mental, to deal with some of these things, I will target those biggest things. But that brings me back to the point I made earlier about him accusing doctors of being bad medical practitioners by putting people onto statins. The thing is, to use his own words against him, people have only so much they can give, financially or otherwise. Most of the people that end up on statins most likely have not got it in them, just mentally, physically, emotionally, financially, whatever it is, to make those changes. And so for those people, statins actually are likely to benefit them. Yes, ultimately, it would be my absolute preference to get these people off their statins and get them cured of their type 2 diabetes. And this is the work that I do with patients who want to do it. But I'm also a GP that sees many people who do not want to go on low carb, ketogenic, or carnivore diets. They don't want to make those changes. And realistically for them, statins are useful. As I say, you can either be healthy or you can go on to statins. You don't need both. You can't really do both, but you need to do one or the other. The other thing, again, just to wrap it up, this is the women's health study. It's not really for men, though it is almost certainly applicable in all age groups. The risk factors are basically the same. Small dense LDL, really, really important. Deal with all of your cardiovascular risk factors, not just type 2 diabetes. Low carb, ketogenic, ketovore diets are amazing. This is what I currently do. This is what I currently teach to my patients. My Primal Fusion diet, similar to Dr. Ken Berry's proper human diet with some small variations. I don't think he worries about the anti-nutrients anywhere near as much as I do. I think these are really important things to be thinking about. I don't think he worries about them particularly. But I take issue with him saying that some doctors are bad because they're prescribing statins when he is not the one that is seeing those patients. Thanks, guys. I'll see you in the next episode.